So, cervical cancer. Okay, pap smear is intended to identify early preneoplastic lesions of the cervix. Since 1950, when pap smear was introduced and approved as first-line screening tool, the biology of cervical cancer changed dramatically. Now we know that HPV is necessary to have cervical cancer. No HPV, no cervical cancer. So with vaccination, we expect to have a society without cervical cancer. And since HPV is the necessary cause, we can just screen women for HPV, the cause, rather than screening for the neoplasm. So now the screening is intended to identify at-risk populations rather than people with early lesions. So this is a completely different perspective. The vaccination HPV is not only responsible for cervical cancer, but is associated with many neoplasms, head and neck, anus, vulva, and penis. A considerable proportion of this cancer is HPV related. On the other hand, in case of cervical cancer, 100% of cases are due to HPV. This is why screening for HPV is so effective. In Italy, vaccination is not compulsory. Epidemiology. There are some geographic areas that are more exposed, like South America and Central America and Eastern Africa and some Far East areas. South America and Central America have been the areas where the first studies about cervical screening with biomarkers for HPV have been performed. Young ages, HPV infection has a peak and then a slow and progressive decrease with increase in age, while the opposite trend happens for cervical cancer. This pattern demonstrates that one is a cause of the other. So, anyway. HPV is a large family of viruses. You can divide them in high-risk HPV, type 9, 11, 16, 18, 33, 35, 51, for neoplastic transformation of genital epithelium. And serotypes 16 and 18 are the main one involved. And low-risk HPV, that are all the others. The large amount of HPV infections occur at young age and decline later on. This causes these patients to be exposed to the risk of HPV persistence and theoretically to the risk of cervical cancer onset. This is why vaccination is given at a population with that specific age. Effect of screening: the wider the population coverage with screening programs such as pap smear, the lower the incidence of cervical cancer. The moment with pap smear, the result is not optimal. Indeed, the main limit of cytological screening is sensitivity. For a screening tool, we require sensitivity, specificity, reliability, reproducibility, ease of use, and inexpensiveness. The minimal level of sensitivity for a diagnostic tool should be 70–75% in relation to the prevalence of the disease. The sensitivity of pap smear is variable, and in the best case it's never more than 65%. That is 35% of cases. In 35% of cases we have a negative pap smear with a false negative result. You can improve the sensitivity by repeating the pap smear. And in Italy it's like every 2–3 years. In UK and Germany yearly. The more frequent, the higher the cost, obviously. The biomolecular approach, HPV DNA testing, allows to reach a sensitivity close to 100%. Moreover, HPV DNA negative patients not only have no lesions, but they don't have the cause for cervical cancer. So we can distinguish between safe between at-risk population and safe populations. Since this test is so sensitive, we could also, theoretically, avoid repeating the test. In practice, we can delay the testing, which means that you optimize the costs. 5-year interval is a very safe interval, since studies on large populations have shown that no lesion can develop in this interval. Indeed, after HPV infection, according to the natural history of the pathology, you need 13-17 years to develop cervical cancer. This means that with a 5-year interval, you do not have the risk to underdiagnose of cervical cancer or a preneoplastic lesion. Pap smear still has a very good specificity, 95-98%, which means that we have a very low rate of false positive results. This allows us to combine the testing of HPV DNA with the pap smear cytology co-testing, allowing to reach both high sensitivity and specificity. If we have an HPV positive patient with a negative pap smear, it means that this is a high-risk patient. At the moment, the first level of screening is HPV testing, and then, if positive, pap smear cytology. HPV 18 and 16 alone cover 89-93% of all squamous cervical cancer. Okay. A large number of HPV assays are available on the market. The most used is the one of hybrid capture, but others are present and many have FDA and EMA approval. Hybrid capture is the gold standard to which every new test is compared in order to be approved and introduced in the market. Okay. In this paper, they demonstrated that performing one single HPV testing is more protective both in terms of diagnosis and in terms of reduction in mortality than doing nothing, or doing traditional cytology or doing visualization after acetic acid, which is the technique of colposcopy. The conclusion of this paper states, in a low resource setting, a single round of HPV testing was associated with a significant reduction in the numbers of advanced cervical cancers and deaths from cervical cancer. This is a clear demonstration that HPV testing can be considered the optimal screening for prevention of cervical cancer. Okay, then other papers. The negative predicted value is really high. It means that if you are negative at the test, you are safe, you won't develop cervical cancer or any perineoplastic lesion. The incidence in this paper you see that the incidence of SIN3 plus lesions changes according to the testing method which is used. This is quite high in case of cytology, lower in the case of patient if the same patient screened with HPV DNA testing, even lower in the case of co-testing. Anyway, in this difference between HPV testing alone and co-testing is not significantly different. Okay. HPV DNA testing is recommended only in patients more than 35, not before. Indeed, before 35 years of age, the prevalence of regressive HPV infection is higher compared to the risk of persistent infection, and by doing HPV DNA testing, you would risk overdiagnosis. So there is also the risk to have before 35 years normal HPV infections which don't however get per, don't persist. Okay. Vaccination. It would be useful to do vaccination instead of repeating control. But now the first vaccinated women are still quite young, it is quite 25 years old, and we cannot yet be 100% sure that no lesion will occur, even if the immunogenicity of the vaccine is quite good. These women are screened with cytology as a first level test, and with both HPV DNA test and cytology and as a second line test. Moreover, 1% of cervical cancer is not HPV related. What? Good. The risk of getting a cervical cancer in high-risk HPV is 1 over 3,500 if you have a high-risk strain. 95% of these infections regress spontaneously. The remaining will evolve towards cervical cancer, passing through scene 1 to scene 3, with a reduction in the possibility to go to the next step of 30-40% per step. Okay.